Hi, everyone. So welcome to our fourth CanVector National Thrombosis Seminar of the year. So my name is Joseph Shaw. I'm a hematologist and thrombosis medicine specialist at the Ottawa Hospital, and I'll be your moderator for today's session. So just a few friendly reminders. Monthly seminars will be hosted live on this platform throughout the academic year. And we aim to feature state-of-the-art thrombosis or VTE lectures presented by both Canadian and international experts. Video recordings of the seminars will be available online at canvector.ca. And another friendly reminder that the CanVector National Thrombosis Seminars are a self-approved group learning activity as defined by the Maintenance of Certification Program of the Royal College of Physicians and Surgeons of Canada. So this is the CanVector National Thrombosis Seminars Planning Committee. I'm the chair of the committee, and you can see the other members here. So today's presentation is going to be on the NLRP3 Inflammasome and Interleukin-1 in thromboinflammation and VTE. Today's presenter is going to be Dr. Nicola Potere. He is a postdoctoral fellow at the G. D'Annunzio University of Chieti Pescara, Italy, where he recently completed his residency in internal medicine. He obtained an MD from Campus Biomedico University in Rome and completed research fellowships at the Virginia Commonwealth University in Richmond, Virginia, USA, and the Ottawa Hospital Research Institute here in Canada. Dr. Potere is a member of the ISTH Early Career Committee and the ESC Working Group on Thrombosis Young Researchers, and he serves as a junior associate editor for the Journal of Cardiovascular Pharmacology. Dr. Potere's main areas of research include thromboinflammation and cancer-associated thrombosis, and with an H-index of 19 and over 50 publications, I think it's fair to say that Dr. Potere is well on his way to being a widely recognized expert in this field. So welcome, Nicola. We are so happy to have you as a speaker today for our National Thrombosis Seminar. And just before I hand over, so the learning objectives for today, so after this seminar, participants will be able to understand the clinical and mechanistic role of thromboinflammation for VTE and VTE-related complications, recognize the multifaceted contribution of the NLRP3 inflammasome, pyroptosis, and interleukin-1 cytokines to VTE development and progression, and discuss innovative strategies to measure and therapeutically target thromboinflammation in VTE. So a few other reminders, there won't be any questions during the presentation itself, but then after the presentation, there will be a 15-minute Q&A session. But with that, Nicola, thank you again for being here, and I'll hand over to you.
Thanks so much, Joe, for the introduction, and thank you so much for having me. It's an honor and a really great pleasure. Thank you very much. So our talk today is about the role of the NLRP3 inflammasome and interleukin-1 in thromboinflammation and VTE. These are my conflicts of interest.
Oh, Nicola, you just need to project your slides.
Oh, yeah. Sorry. I did it earlier. Sorry about that. Okay, we're close. Okay, can you see the slides?
Yep.
Yes, yeah, it does seem like it's not currently in presentation mode. I don't know if there's a way that you can.
Yeah.
There we go. Perfect. Thank you.
Sorry about that. So again, thank you very much for having me and for the introduction. These are my conflicts of interest. So the outline for today's talk is to first define what immunothrombosis and thromboinflammation are, what is the role of inflammation and anti-inflammatory cytokines in VTE risk and prognosis, and just provide a very brief schematic overview of the NLRP3 inflammasome interleukin-1 pathway, and discuss select cell-specific mechanisms by which the inflammasome and interleukin-1 are critical to thromboinflammation and VTE, and then discuss strategies to therapeutically target the inflammasome and interleukin-1 in VTE. And then to conclude, just discuss and highlight future exciting perspectives in this field. So the notion that inflammation is strictly intertwined with coagulation and thrombosis is very long in history. We are used to have it linked with the Dr. Virchow triad. However, there are many scientists that have been, linking inflammation with thrombosis before him. For example, the British surgeon Charles Tyre wrote that obstruction, so blood clot, may commence in the primary inflammation of a trunk. The noted John Hunter, another English surgeon, a year later, first introduced the term phlebitis to refer to inflammation and thrombosis. And a few years later, another noted scientist wrote that violent inflammation of the veins may be associated with gradual coagulation of the contents. And then Jean Cravelier was one of those people that most supported the inflammatory hypothesis of venous thrombosis in his book entitled Phlebitis Dominates All Pathology. And then we get to our Dr. Virchow, and we are very used to see the Virchow's triad in several reviews and articles. And most of the time, inflammation is included in the triad, in the triangle, most often under the hypercoagulability component. But I'm pretty sure that Dr. Virchow wouldn't be happy to see that, and maybe would have rejected many of these articles if he could be a reviewer, since he spent most of his career trying to dispute the inflammatory theory of thrombosis, since he wrote that there is no fact to prove this inflammatory hypothesis of thrombosis, and we should rather leave inflammation on the side and focus on thrombosis. But rather, his most notable contributions were to demonstrate in different ways with animal experiments and autoptic studies that pulmonary thrombosis does not form in situ, but rather is the results of blood clots traveling from other veins, for example, from the veins of the leg. And so he coined the two terms that are thrombosis and embolism. And so the triad of factors that are attributed as causes of venous thrombosis are rather consequences of venous thrombosis, as Dr. Virchow wanted to say. So the consequences deriving from blood clot can be the irritation of a blood vessel, further blood coagulation, and obviously interruption of the blood flow. So I was curious to see how inflammation was included and also represented in different models across time of venous thrombogenesis. And it was very interesting to see that inflammation has gained more and more importance in these models as our understanding of the immune functions increased. Also, the relevance of these processes within venous thrombogenesis also increased. So we see in the panel, in the first panel, that there are some inflammatory cytokines present, and then we transition, in 2013 by a seminal review by Nigel Mackman with a cell-based model of coagulation that also critically includes monocytes and other immune cells. And also, we see that inflammatory cells and soluble inflammatory mediators have greater importance. And now I've just taken two figures of two recent reviews. We see that most of the players are inflammatory, so either cellular immune cells or soluble inflammatory mediators. Nowadays, a recent paradigm has been recently introduced in which inflammation and thrombosis are tightly connected processes, and both contribute to pathogen containment in host defense response. So thrombosis is really nowadays can be regarded to as an intravascular effector of innate immunity, which Drs. Engelmann and Masberg termed immunothrombosis, whereas dysregulated or excessive immunothrombosis are referred to as thromboinflammation, and thromboinflammation is responsible for undesired collateral organ damage caused by microvascular and macrovascular thrombosis. So thromboinflammation really is a vicious circuit of platelet, endothelial, and immune activation that unleash the complement system and the coagulation cascade. So we can further reinterpret this notion as hemostasis being a physiological defense response when vessel injury occurs. And when this process is dysregulated or unwanted or excessive, we have thrombosis that causes disease, obviously a thromboembolic disease. So similarly, immunothrombosis can be considered as a response to pathogen invasion, as the clot is an evolutionary conserved response that aims at entrapping the pathogen within the clot to limit pathogen replication and dissemination. And when the immunothrombotic response is excessive or unwanted, undesired, we have thromboinflammation that's similar to the classical thrombosis, has a critical role in thromboembolic diseases. So inflammation is a critical factor to VTE, and inflammation represents a strong prothrombotic milieu that favors VTE development. For example, it is well established that several VTE risk factors such as infections, acute illness, trauma, surgery, but also unhealthy aging and CHIP, so clonal hematopoiesis of indeterminate potential, as well as cancer and cancer-directed treatments, cause or induce or are associated with inflammation, being this acute inflammatory response, or rather chronic low-grade inflammation, or sometimes subclinical inflammation. And altogether, this common inflammatory prothrombotic milieu is critical for VTE to occur. So there have been hundreds of studies showing associations between inflammatory biomarkers and the risk to develop VTE. Here, I just wanted to point out that CRP, so C-reactive protein, that is the preferred inflammatory biomarker for cardiovascular risk stratification, has been previously shown not to play a causal role in cardiovascular disease, but CRP is an acute phase protein produced by the liver, and CRP is critically induced by both interleukin-6 and interleukin-1 beta. Therefore, CRP is commonly and widely used as a surrogate for, or as a proxy for interleukin-6 and interleukin-1 activity. So again, inflammatory biomarkers have been associated with a 2 to 5-fold increased risk for VTE. And this association seemed to occur independently of the cause, so of the nature of inflammation. This has been shown consistently in acute illnesses, so underlying acute inflammation. As we see in panel A, we see that the risk to the incidence for VTE progressively increases with higher CRP levels. And in panel B, we see that the association between elevated BMI, so obesity, and the risk for VTE is presumably mediated by inflammation, as shown by progressively higher CRP levels that increase with higher rates of thrombosis. And also, I have also selected this very recent study by the Vienna group showing that in cancer patients receiving immune checkpoint inhibitors, patients who exhibit rampant increases in CRP following ICI initiation are significantly higher risk to develop VTE as opposed to patients whose CRP remains stable or declines. And in the other studies I have selected are taken from the general population, panel B, and shows that the association between inflammation, so CRP, and the risk for incident VTE is pretty clear, and somewhere between 2 and 5. And again, it is also present in patients from the general population with subclinical inflammation. And also in panel E, this is another meta-analysis of prospective population-based studies showing a linear dose-dependent association between CRP levels and the relative risk for VTE among healthy subjects. So inflammation not only plays a critical role in VTE development, but VTE itself also induces a robust inflammatory response that can persist starting from the very acute phases to the subacute and remote stages post-VTE. So inflammation following VTE is reflected by marked elevations in a number of inflammatory indices such as leukocytes, CRP, and individual cytokines. And also has been associated with larger thrombi to aggravated endothelial damage, and chronic non-resolving inflammation further contributes to venous hypertension, thrombus organization, residual vein obstruction that are pertaining to the thrombus itself, but also affects the vascular response after a thrombus formation as it predisposes to matrix changes, capillary leakage, and vein wall thickening and scarring. And altogether, this may have a role in the development of adverse clinical outcomes and complications of VTE. So I have highlighted a few studies that have been showing this. So for instance, failure to resolve adequately resolve inflammation after VTE has been associated with persistently elevated biomarkers of hypercoagulability and with altered fibrinolysis. Sorry, I have this. And with markers of vascular proteolysis and fibrosis. And interestingly, several inflammatory biomarkers exhibit great correlation with DVT and PE severity, including the anatomic extent and worse quality of life. So somehow the magnitude of the inflammatory response after VTE is associated with clot burden. And also, and importantly, dysregulated inflammation after VTE has been associated with residual vascular obstruction, and after PE, it has been associated with right ventricle dysfunction, both in the short and long term. In this study from the BioSox, in this figure from the BioSox study, the authors show that CRP and interleukin-6 that remain elevated at 1 and 6 months strongly and independently predict the occurrence of the post-thrombotic syndrome at 24 months. And in another study, there was in agreement with this study, showed that elevated CRP at 12 months after unprovoked DVT was similarly associated with an 8-fold increased risk for PTS. Inflammation may also play a role in recurrence. Among the several studies, I've selected this study from Dr. Yara Palomares, where he showed that CRP greater than 4.5 at the time of anticoagulation discontinuation for cancer-associated VTE was associated with a 10-fold higher risk for recurrent VTE. And then I've also selected this very recent study from the Riede investigators, where they have tested different inflammatory indices, and all of them were strongly associated with a higher risk of mortality. And this association seemed to be independent, so seemed to be present regardless of PE severity at baseline. So let's delve into the mechanisms of some of the mechanisms of inflammation. So the NLRP3 inflammasome and interleukin-1 are key regulators of the innate immune response. There are several inflammasomes that have been identified. But the NLRP3 inflammasome is the most studied inflammasome and foremost the most engaged in cardiovascular pathology. So just briefly, if the inflammasome and interleukin-1 are pretty much ubiquitous, so they are present in pretty much every cell type. And depending on the cell type, the inflammasome can be already active, so can be already active when needed, or requires some sort of processing before it gets active. But generally, the phases that lead to inflammasome activation are categorized in 2 steps that are priming and triggering. So the priming can be induced by a number of stimuli, including lots of cytokines, chemokines, cellular components such as extracellular DNA, cellular debris after cell death, and so on. But generally, they are categorized into DUMPs and PUMPs. So DUMPs are damage-associated molecular patterns that are usually released after sterile injury, whereas PUMPs, which stands for pathogen-associated molecular patterns, are released upon infection, so during infectious diseases or infectious stimuli. So regardless of the stimuli, there are a number of membrane receptors that mediate signaling. And for priming, these signals result in NF-kappa B activation and translocation to the nucleus, where transcription of NLRP3 inflammasome components occurs. And subsequently, additional stimuli are required for the inflammasome to assemble and become active. So when these stimuli occur, they can be due to oxidative stress, lysosomal damage, changes in intracellular ion concentrations, and so on. The NLRP protein that we see here acts as an intracellular sensor for stress or damage. So it assembles and forms a macromolecular effector platform that is termed the NLRP3 inflammasome. The inflammasome also recruits caspase-1, that is a critical enzyme. So caspase-1 is capable of undergoing autocatalytic activation. And once active, it processes interleukin-1 beta and interleukin-18, and it converts them to biologically active forms that are ready to be released. But also caspase-1 is critical for the release of these cytokines, but also to pyroptosis, as caspase-1 cleaves gasdermin D. It forms fragments of gasdermin D that migrate to the membrane, to the cell membrane, and where they form membrane pores. So on the one hand, these pores enable release of active interleukin-1 cytokines, and on the other hand, they can lead to pyroptosis that is highly relevant in several disease states. And pyroptosis is also termed inflammatory cell death. So once released, these cytokines can bind to target cells. Again, pretty much every cell type can be a target for interleukin-1 activity, as most of the cells express IL-1 or IL-18 receptors. So once they bind to their receptor, they induce IL-1 signaling that is also mediated by NF-kappa B, that also, again, translate target genes that are critical for inflammatory and thromboinflammatory responses. And also the interleukin-1 signaling is highly regulated at multiple levels, including at the receptor level, since it is a critical step in the immune response. So for example, I just wanted to highlight the interleukin-1 receptor antagonist that is an endogenous counterpoint to IL-1 signaling. So I just wanted to highlight that because of its critical role in health and disease, several agents that target either the inflammasome, interleukin-1, or interleukin-18 have been developed. And there is really incredible interest in developing and advancing research and drug discovery in this field. But among these ones, there are several other novel blockers that are in the pipeline. But among these ones, I would like to highlight colchicine, which is used already in clinical practice, and also anakinra that is used for a number of autoimmune and rheumatic diseases, and also rilonacept that has been recently approved for steroid-resistant pericarditis, and maybe it will be the same for these other gofligicept that has been recently shown to have great efficacy and safety in patients with pericarditis. So now I would like to show cell-specific roles of the inflammasome and interleukin-1, and how the activation of these molecules in specific cell types contributes to thromboinflammation and VTE. So I started with innate immune cells. So innate immune cells are critical to the pathogenesis of venous thrombosis. They are critical drivers of thrombogenesis through several mechanisms, including tissue factor expression and generation, but also thanks to netosis. So the inflammasome and caspase-1 are prerequisite for tissue factor expression on the wall on the cellular membrane, but also they are critical to enable expression and release of tissue factor by means of extracellular vesicles. And this is shown, it is demonstrated by this study that I wanted to highlight, very elegant study in which mice lacking either caspase-1 or gasdermin D fail to produce and activate tissue factor. And this is also evident from the reduced thrombin antithrombin complexes in blood. And this translates into dramatically reduced mortality in a mouse model of septic shock and disseminated intravascular coagulation. As I was mentioning, the inflammasome is also required for netosis to occur, as the inflammasome and caspase-1 participate in chromatin decondensation and also in the formation of the pores through which chromatin is projected, so in net formation. And this is also demonstrated by this study in which mice lacking the inflammasome do not produce much less nets, and thrombi from mice that lack the NLRP3 inflammasome are significantly smaller and have significantly fewer nets within the thrombus. So not only the inflammasome and interleukin-1 are critical for netosis to take place, but also once nets are forming, interleukin-1 are essential mediators for net-induced thrombogenicity and thrombus formation, as they enable docking of nets, forming nets to the endothelium, and therefore this is a study from Dr. Peter Libby group showing that if cells or mice are treated with blockers to interleukin-1 beta or interleukin-1 alpha or the interleukin-1 receptor, nets are not able to induce thrombosis. And then we get to another important critical player of venous thrombosis that are platelets. On the right side, we see that activated platelets have robust expression of the NLRP3 inflammasome in green. And also we see that injection of interleukin-1, of small amounts of interleukin-1 into the blood of rabbits is capable of inducing platelet aggregation, including both homotypic and heterotypic, so platelet to neutrophil aggregates in the blood of these rabbits. And platelets, as we were just mentioning, are able to actively produce abundant amounts of interleukin-1 via NLRP3 inflammasome activation. But also there are some very interesting studies showing that platelets are able to uptake vesicles containing interleukin-1 beta, and they can release them upon stimulation. So not only this, but also the inflammasome on the other end, inflammasome interleukin-1, are critical regulators of platelet maturation, activation, and aggregation. Here we see that mice that lack, so platelets that lack the inflammasome and are exposed, triggered with collagen or thrombin or ADP or ATP. So there are several studies showing this, fail to become active. So if the inflammasome is lacking, platelets become less active. And also the same behavior is reproduced when platelets are treated with an inflammasome blocker or with a caspase-1 blocker. So not only platelets are less active when we interfere with this pathway, but they also aggregate much less, as seen by this graph, where mice lacking the inflammasome, this is in vivo, this femoral artery ligation model, where mice lacking the inflammasome fail to have platelet aggregation. And this translates into significantly reduced thrombus area, being this obtained in mice genetically lacking the inflammasome, or when they are treated with inflammasome or caspase-1 blockers. So another layer of IL-1 driven platelet mediated regulation of thromboinflammation is the following. As a very recent study has shown that inflammasome platelets not only have these functions that we have just briefly seen, but they are also critical by releasing platelet-derived factors in licensing optimal inflammasome activation and interleukin-1 production by immune cells. So there is, as we know, there is a great intertalk between platelet and innate immune cells, but also between platelet and endothelium, as these other elegant studies show that platelets critically contribute by releasing interleukin-1 beta to activate the endothelium and to induce vascular permeability. And we get to our vascular endothelium. So also endothelial cells are capable of producing interleukin-1 and to activate the inflammasome. But foremost, IL-1 cytokines are critical in endothelial activation and dysfunction, and also in inducing a prothrombotic phenotype. There are studies starting from 1970s showing that interleukin-1 dramatically increases the expression of endothelial adhesion molecules, such as P-selectin and ICAM, but also to increase the expression and production of procoagulant factors, such as von Willebrand factor and tissue factor. And also, in parallel, they reduce the expression of endogenous anticoagulants, such as activated protein C and thrombomodulin. So in the image here, I have shown an image from a pioneering study showing the effects of interleukin-1 on the venous endothelium. And we see that shortly after injection of interleukin-1, the endothelium becomes highly populated with platelets and recruited immune cells, and fibrin filaments form on this endothelium. Again, this is another pioneering experiment showing that, quantitatively showing that interleukin-1 induces robust leukocyte recruitment at the endothelial surface. And this translates into dramatically increased procoagulant activity exerted by the endothelium. And this parallels with dose-dependent increases in factor 10 activation, depending on, so the higher the interleukin-1 dose, the higher the amount of factor factor 10 form. And this is accompanied by reduced expression of the anticoagulant activated protein C that leads to reduced ability to inactivate factor 5. So in this illustration, just to summarize what we have been seeing here, the inflammasome seems to have a critical role in this thromboinflammatory feed-forward loop, as the inflammasome in innate immune cells is responsible for tissue factor expression and release, and it is also critical to netosis. And these two mechanisms are critical triggers for the coagulation cascade. But interleukin-1 and inflammasome are also critical for endothelial activation, leukocyte and platelet recruitment, as well as platelet activation and aggregation. So let's revise the evidence showing a role for the inflammasome interleukin-1 in human VTE. So there have been a few reports showing that patients that harbor very monogenic mutations that cause unchecked inflammasome activation with exaggerated interleukin-1 release, strongly predisposed to VTE. There is also a very recent study published in Nature showing this association in patients with the VEXAS syndrome. And also there's some reports showing that patients with acute VTE, including some studies enrolling cancer patients, that demonstrated that VTE is associated with strong, robust upregulation of this pathway. But we go back to our animal models, and so a number of studies have demonstrated that VTE and subsequent vein wall injury induce a robust inflammatory response that is mediated by the inflammasome and interleukin-1 cytokines, and abundantly increased protein levels, but also messenger RNA transcript levels have been demonstrated both in the thrombi and in the thrombosed vein wall segments, but also in circulating in the blood and individual cell types such as peripheral mononuclear cells and platelets. And in this other very elegant study, the authors show that inflammasome is abundantly activated in venous thrombi and predominantly co-localized with platelets, as we see from the image on the left-hand side, but also with nets. And we have seen earlier why this can be. And also here the authors show that almost the majority of nets of netotic cells have an active inflammasome in their cytoplasm. And this is and when these mice are treated with a caspase-1 inhibitor, they are protected against thrombosis, so they develop significantly less thrombi despite obviously inferior vena cava ligation. And when thrombi form, they are significantly smaller as assessed by weight and also size, which I did not report here. And so similar results, so very consistent results have been shown recently in similarly elegant studies. So these other studies, showed similar behavior when caspase-1 is knocked out or castermin D is genetically lacking in mice. And again, another study that showed that either treatment with an interleukin-1 monoclonal antibody or with the interleukin-1 receptor inhibitor, anakinra, that is approved for clinical use, as we mentioned earlier, they result in reduced VTE formation, and when thrombi form, they are much smaller. So again, this summarized some of the evidence showing that regardless of the strategies that investigators have used to interfere, to inhibit the NLRP3 interleukin-1 pathway, the outcome seems consistent, which is reduced venous thrombus formation and propagation. So, it appears that the inflammasome interleukin-1 and more generally inflammation have a critical role in VTE. However, therapeutic efforts in our field have almost exclusively focused on targeting the coagulation cascade with the introduction of VKAs, low molecular weight heparins, and more recently, direct oral anticoagulants. But it is evident that this current anticoagulant really effectively target and inhibit the coagulation cascade, but are obviously associated with an inherent risk for bleeding. And foremost, as we see in clinic, unfortunately, often they cannot completely prevent VTE, so primary events, and also recurrent VTE and complications such as recurrent VTE, the post-thrombotic syndrome, and the post-pulmonary embolism syndrome or impairment. Therefore, it is becoming more and more clear that inflammation plays a critical role in pathogenesis of VTE, but yet remains a largely neglected therapeutic target, thus unveiling a very important unmet therapeutic gap. So it has been advocated that anticoagulants have some sort of anti-inflammatory activity, which is true, and probably the anti-inflammatory activity is mild. But and maybe some anticoagulants seem to have more anti-inflammatory activities, as it has been advocated for low molecular weight heparins and factor 10A inhibitor. But anyways, they seem to be insufficient alone to address inflammation, as shown by the residual inflammatory risk present in some of the studies that we have seen earlier. And statins, similar to anticoagulants, have anti-inflammatory activity. They can protect the glycocalyx. They dismantle nets. They have mild effect on reducing interleukin-1 levels and CRP levels. And importantly, they have been shown clinically to reduce primary VTE events by 47%, as for the case of rosuvastatin. And since patients enroll in two of these trials, such as the HOPE-3 trial and the Jupiter trial, had normal lipid levels, this effect seems most likely due to the anti-inflammatory effects of statins, which again further point to the inflammatory effect, to a key inflammatory role of inflammation in VTE pathogenesis. And interestingly, there are some studies, including one led by Dr. DeLuc, that is testing statins for prevention of BTS and recurrent VTE after VTE, the SAVOR trial. So I then wanted to focus on colchicine. So colchicine was originally thought to function as a microtubule inhibitor only, but it has become around 2013 shown that colchicine potently inhibit inflammasome activation, as microtubules are essential to enable inflammasome assembly and oligomerization. So automatically colchicine becomes the most studied inflammasome inhibitor, since colchicine was already used for its anti-inflammatory properties in the ancient Egypt. So studies have shown consistently that colchicine reduces inflammasome activation and IL-1 release, but also is capable of reducing neutrophil recruitment, degranulation, and netosis. And also it modulates platelet activation and aggregation. So the colchicine is a very old inflammatory drug that is still used for a number of inflammatory diseases, such as gout or pericarditis. And a recent FDA review on this drug established colchicine to be safe and well tolerated, and with side effects, primarily GI side effect, being associated with inappropriate dosage and with doses greater than 2 to 3 milligrams. Or colchicine use in patients with kidney or liver insufficiency. Relatively recent studies, such as the COLCOT and the LODOCO-2 trials, have demonstrated potent antithrombotic efficacy of colchicine in patients with coronary artery disease. And these patients had on board optimal antithrombotic therapies already, including antiplatelets and anticoagulants in up to 10 to 15%. And colchicine, in addition to current antithrombotic therapy, did not increase the risk for bleeding. And as we see from this image, overall, these are the results of a meta-analysis of all colchicine trial in CAD, was associated with a 36% reduction in myocardial infarction and a 50% reduction in stroke. And importantly, colchicine has been recently approved by the FDA, becoming the first anti-inflammatory drug approved for secondary cardiovascular prevention. To get to the conclusion, I just wanted to share with you this study that is one of the few studies testing colchicine in VTE models. So the investigators have administered colchicine or heparin alone or in combination, given an hour after IVC stenosis and every 12 hours until day 3, when the clot was examined. And impressively, colchicine alone was able to reduce clot formation and size. Also qualitatively, we see that the changes associated with colchicine treatment within the thrombus. And foremost, colchicine, when was co-administered with heparin, reduced by 20-fold the heparin dose required to prevent thrombosis. and co-administration of really small amounts of colchicine and heparin were able to reduce clot size by 60%. And when colchicine was added to heparin, that addition, addition of colchicine to heparin did not increase tail bleeding as assessed by tail vein bleeding time. And also, just briefly, I wanted to highlight this very nice study from a Boston group from Dr. Jaffer, in which they showed that colchicine treatment after DVT induction was associated with reduced markers of inflammation, fibrosis, and proteolysis, both circulating markers, but also inflammation, fibrosis, and proteolysis assessed within the vessel wall, and did not affect, so they did not delay thrombus clearance. And these changes were accompanied by reduced vein wall injuring and scarring, which altogether show great promise for PTS prevention. So as we get to the conclusions, targeting the inflammasome interleukin-1 may reduce thrombus formation and propagation and possibly mitigate vein dysfunction and scarring. Therefore, these new treatments may serve as adjuncts to anticoagulants and possibly may synergistically maximize the benefits of anticoagulation, reduce post-thrombotic syndrome and recurrent VTE, possibly circumventing the risk of bleeding. Therefore, we have been working in the last couple of years on the implementation of a randomized controlled trial, the colchicine to quench the inflammatory response after deep vein thrombosis trial, the CONQUER DVT that is ongoing. Recruitment is expected to start very soon. So we will first conduct a pilot phase trial to first assess the feasibility of conducting a full-scale trial to demonstrate the safety and efficacy of low-dose colchicine, so 0.5 milligrams once daily for 6 months for the prevention of PTS and recurrent vascular event. It will be a Vanguard phase double-blind, placebo-controlled randomized trial conducted in Canada and Italy. And we're planning to enroll adult subjects with a first symptomatic episode of confirmed acute proximal DVT of the lower extremity, who have started anticoagulation within 7 days, and anticoagulation will be left to the discretion of the treating physician. And just as an outline of the study procedures, the study is thought to be very pragmatic, with 2 in-person visits at 6 and 12 months, and with a target enrollment of 250 patients. For the pilot trial, the primary outcome will be feasibility, whereas for the full-scale trial, but we will also assess the same endpoints using the same methodology, will be the incidence and severity of PTS, recurrent VTE, arterial thromboembolism, major and clinically relevant non-major bleeding, and changes in quality of life at 6 and 12 months. So to conclude our discussion today, thromboinflammation and the inflammasome IL-1 pathway are increasingly becoming apparent major pathogenic drivers of VTE and ensuing complications through mechanisms that involve immunity, coagulation, and the vascular endothelium. It is also supported by the abundant, rapidly accumulating literature that the inflammasome interleukin-1 is upregulated following VTE, and is strictly associated with adverse prognosis, and solid preclinical evidence with the indirect clinical evidence support great potential for inflammasome interleukin-1 based therapeutics in VTE. Therefore, selective targeting of the inflammasome and interleukin-1 as adjunct to anticoagulant therapy holds great promise for improving VTE prevention and management. And I want to end my talk with some of the questions that are very exciting, but they remain still unanswered. One of the points I have identified as a primary need and field for further research is to refine the inflammatory risk stratification and prognostication through advanced multimodal approaches. These may encompass biomarkers, or specific biomarkers that are able to actually detect and assess both systemic and local inflammation, and also the development and application of advanced imaging techniques for quantitative and qualitative assessment of vascular inflammation, but also of intrathrombus inflammation. Second, further research would be needed to improve current mechanistic understanding of VTE-specific inflammation and establish novel druggable targets that are able to modulate immunity without disrupting critical immune functions that hold solid translational prospect. And finally, to identify optimal patient candidates, responders, and treatment windows for anti-inflammatory interventions, so to maximize the clinical benefits and minimize the drug-related side effects that are associated with these drugs. So some of the strategies may be time-optimized treatment and the use of novel modern technologies that may enable targeted drug delivery to the thrombus or to the injured vein. And with this, I would like to end and thank you everyone for your attention, and my mentors without whom I wouldn't be able to have done this presentation, and some of the works that I have had the chance to cite and to use for this presentation. And foremost, my research group in Chieti and my collaborators and friends that I had the privilege to meet along the way and to learn from. Thank you very much.
Thank you very much, Nicola, for that whirlwind tour of thromboinflammation. Just because we're a bit over time, I'll maybe limit things to one question here. Dr. Yan Xu, who you know did have a few questions, and I'll maybe read out one that I think is a high-yield question for discussion here, but he's just asking, where do you see the role of anti-inflammasome agents based on their efficacy for VT prevention compared to anticoagulants? So do you see it more as an adjunctive therapy to anticoagulation, as you're proposing in CONQUER-DVT? Or is there maybe even a place for these agents as primary prophylaxis among individuals without VTE in high-risk settings, as we would typically think of prophylactic anticoagulants, for example?
Well, thanks so much for the so well-taken question. I think it depends. Obviously, we need more data because there are very limited data at the moment. So my opinion is that it depends a lot on the clinical scenario. So there is a study from the Netherlands, a very recent study from the Netherlands. It's retrospective, so with some limitations, showing that patients that were with autoinflammatory diseases that were taking colchicine were protected from VTE. So this might be one of the scenarios where adequate anti-inflammatory therapy can be sufficient or at least help in VTE prevention. But apart from these scenarios, I'm not sure whether they will be sufficient and may substitute anticoagulation prophylaxis.
Thank you very much. So with that, we'll conclude. Caleb, I don't know if we can get the conclusion slides, but and maybe Nicola, I'm not sure if you need to stop sharing.
Oh, sorry.
Yep, there we go. So thank you again, Nicola, for offering to present and such a great presentation. Recordings will be available at the link that you see here. Just a friendly reminder to please complete the seminar evaluation. And also a friendly reminder that our next seminar is already booked. It will be March 18th, and this will be featuring Dr. Ching and I, who will be presenting on the role of biomarkers in cancer-associated VTE and hemostasis. So again, thank you, Nicola.
Thank you for having me. Thanks.